Well, good morning and welcome to Grand Rounds here at the Houston Methodist DeBakey Heart and Vascular Center. I have the ignominious distinction of being drafted to introduce the man who needs no introduction. That's a sign of true trust. But before I do that, I do want to make one announcement. And Tyree, you may want to step back up here for a minute because I want to make sure everybody understands the processes of DeBakey education. It's morphed fairly significantly, but what has remained the same is that Tyree is kind of the go-to person for everyone in the education department. And he works with two of the video production folks, George and Obed, who've been with us all along. They now kind of report up through creative services, otherwise known as marketing. But the bottom line is the process of getting them involved is he's the guy, Chris Ibarra, who is employed by us, works with him. And the good news is it's free. The bad news is if we don't use it, it's going to be used for other things. So I'm talking to all the people who are in the different leadership positions here in the Heart and Vascular Center. Use it or lose it. I don't mean use it, I mean use it collectively. And so Tyree is hardwired into this. Chris can help move things through. Think of this in terms of using the studio, free, using Mighty, free, using video production capabilities, free, but you got to have a plan. It can't just be, they can't get bombarded willy-nilly, but please think about how we can continue to grow our education portfolio. A good, Tyree?
That's good.
All right, so back to the task at hand. Really, why am I standing up here to introduce Dr. Zoghbi? He's got just an unbelievable career. Joined the faculty at Baylor in 1985. And then, of course, moved over to Methodist, after the Baylor-Methodist split occurred. Has built one of the best, probably the best imaging center in the United States and in the world. Now has taken over the job basically as chair of the department. And so I describe him really as my partner in crime. Our job is to herd the collective masses, which is easier said than done some of the times. But we're very proud really of what's been created here. He has been the past president of the American College of Cardiologists, has published over 350 papers, has chaired in almost 5 national guidelines groups and been the lead author in those publications. So there's not really anybody else that I can think of who can give you a better perspective on the topic at hand today, and that's mitral regurgitation, evolving concepts in diagnosis, prognosis, and management. Thank you, Bill. Thank you. Thanks.
Thank you, Alan, and thank you also for your partnership, your kind words. But I think the most important thing is, yesterday we had interviews and people were asking whether we work well with the surgery department. And let me tell you, we're joined at the hip, and it really is an amazing partnership over the years. So many of the things that I'm going to share with you is the product of collaborations within our departments, within the Heart and Vascular Center and beyond. So I chose mitral regurgitation to talk about, and I will emphasize predominantly primary mitral regurgitation or degenerative MR, and go from the basics, from the biomechanics to at least what are the latest advancements in risk stratification and some of the questions, unanswered questions that we still have in a disease that's been with us since inception. And you wonder always about this mitral valve apparatus. It really is amazing. Just think that this ventricle is pumping at least about 100 millimeters of mercury. And with all the apparatus, annulus, leaflets, cords, valves, and we think about the valves, that you have complete apposition of these leaflets and competence of these leaflets in the vast, vast majority of the time. Many things have evolved. And most of what I'm going to show you today is actually new discoveries or new thoughts over the past 5 years. Just imagine. So if I go back to my training, I use very little of what I understood about mitral regurgitation. And I'll share with you also that we were treating patients who are coming in with primary mitral regurgitation and with depressed ventricular function nowadays that we don't see anymore. So the field has changed in so many ways. Imaging has changed, and you could see from the images here that the mitral valve is not really at the edges a linear structure. It has a lot of ruffles, rugae, whatever you want to call them, And for them to be able to oppose well and have no leakage, you have to have about almost a centimeter of apposition. So you can think that in secondary mitral regurgitation, the deformation of the ventricle or atrium is causing some of that apposition to be much less, and therefore it is a very dynamic process. I'm not going to talk about it most of the time today, but I wanted to share that with you because as we probably tackle secondary mitral regurgitation in a talk sometime down the line, it is very influenced by what you do to the ventricle or to the atrium because the apparatus is rather normal. It is just stretched. And this is an example of primary and secondary MR. Yes, we differentiate them, but not too often. They will coexist together. And I think you have to, at least as an imager or a clinician, you have to understand what is the mechanism of regurgitation. These are the etiologies. And in secondary and functional MR, obviously, the problem is the ventricle or the atria that are so enlarged that the apposition of the mitral valve leaflets is much less. I was asked by Jack Imaging to chair a panel to talk about atrial functional mitral regurgitation, which is an entity that has been tackled, but not as much emphasized, but most importantly, that the criteria were rather all over the place. So what we did in this viewpoint is put some criteria for individuals, hopefully, to converge to a diagnosis and hopefully understand the natural history, the incidence, and what we could do about it. Basically, in this entity, the atria are tremendously enlarged, and therefore the annulus, and you have stretching and tethering of the mitral valve. And you could see in an arrow there on the left is that normally the mitral valve has to have a concave structure towards the atrium. And if it straightens out, you know that the mitral valve is tethered. And this happens both in ventricular mitral regurgitation in addition to atrial mitral regurgitation. And you could see the difference there. The atria are very large. Usually the substrate is atrial fibrillation or diastolic dysfunction of the ventricle, where the atria and the annulus are so enlarged. One important criterion that we proposed, and actually most likely people would converge towards that, is that the ventricle, at least to start with, has to be of normal size and normal function, not only globally, but regionally. And I think what has been missed in the literature is the regional dysfunction, which you could have as a secondary mitral regurgitation arising from the ventricle. Now, obviously, the ventricle will remodel down the line with significant MR. I'll propose to you also that in the atrial functional mitral regurgitation, the criteria of severity will likely be different. You rarely will have a regurgitant volume greater than 60 milliliters in a ventricle that is normal size for somebody who's rather doing well or minimally symptomatic. So keep those in mind. The other interesting thing that I learned is that for atrial functional mitral regurgitation to occur, there is a malbalance of the area of the leaflets in relation to the area of the annulus. The leaflets grow, actually. They're a live structure. So if the leaflets grow enough in response to the pathologic situation, you won't have significant mitral regurgitation. You may not have any. And therefore, I think that was a beautiful study from Dr. Kim just a few years ago. So the others are, obviously, we're going to concentrate on primary MR, the typical Barlow disease or fibroelastic deficiency, which can affect the valve in a certain region or not. It's important for us also to think about the pathophysiology of such a disease. And as opposed to a normal where you could see the nice fibers, et cetera, there's a lot of disarray in myxomatous disease with infiltration. So in myxomatous disease, you have a very large spongiosa with increased thickness of this. But the reason I'm showing this to you is to think that what causes, indeed, flail leaflets? Because this myxomatous infiltration doesn't affect only the valve. It also affects the chordae. So you have chordae that may not be as strong to be able to carry the load over the years of beat after beat. And so you have to think about the total apparatus and maybe about what is stress or strain on the chordae themselves. I don't know, we can measure it at this stage of the game, but it's always good to think about pathophysiology and see how you can affect it. This is stress-strain relation of the mitral valve. And I want to share with you that obviously you could stress and strain the valve too much for it to break. But physiologically, think about deformation. We talk about global longitudinal strain for the ventricle. The valve stretches every beat, about 10%. So you have stresses on this valve. So if you have a substrate of a valve dysfunction, therefore, you're going to have more stresses on the valve itself. And we tried to tackle this for a few years ago, see if we can measure strain, because traditionally you can measure it only in vitro or in animal models where you could put beads on the mitral valve or stain it in different ways for you to be able to do that. What is the strain distribution in man, particularly in vivo, uninstrumented? What does surgical repair do that? And I want to acknowledge the team here. We're talking about, it took about 7-8 years to be able to put this team together to fruition. And this is a partnership with the University of Houston, Dr. Azencott, where we developed a software to be able to do that in vivo in patients undergoing transesophageal echocardiography. And Dr. Ben-Zikri started this work, and Carlos El Talawi is the one heading this project, and now with collaborations with Harvard Group and Mass General and animal models of ischemia. Basically what we did is use the best imaging modality, time and space, and basically be able to measure strain and have a heat map of strain. And these are 3D modeling of a normal and abnormal valve. And this is tracking the mitral valve in systole, and this is a mitral valve prolapse, so you could measure the formation of the mitral valve and plot it in 3D dimension. In mitral regurgitation, as opposed to normal, you have much more strain, much more deformation of the valve. And again, I didn't mention to you, we can't measure strain of the chordae themselves, which could be the problem down the line. And we were wondering whether this increase in strain was actually just related to the severity of regurgitation. So we were straining to look for mitral valve prolapse without regurgitation. And indeed, in the middle, mitral valve prolapse without regurgitation has increased strain and increased deformation. And that could conceivably change over time, change the natural history, because we know from the Framingham data, mitral valve gets actually thicker over time. So it will be very interesting to see that. So strain is much more increased. It relates to thickness. Yes, it's a biological relationship, but it relates to the thickness, which is infiltration, basically, of these valves. In collaboration with Dr. Lowry, we wanted to see what happens if you do mitral valve repair with the preservation technique. And this is, you could see that there, the circular, flexible annulus, surgical annulus. You could see how it can deform. Interestingly enough, strain decreases significantly. I'm not sure about strain on the chordae themselves, but conceivably they do, because they have much less prolapse, if you will, and abnormal tethering of these chordae. So I think it will be very interesting to see what would it look like from a natural history point of view after a mitral valve repair where strain is significantly decreased. So from our earlier data, it is higher in the posterior leaflet strain, in normal and in disease, and conceivably, this could be the pathophysiologic mechanism of where you see calcifications. In the mitral annulus, it is in the posterior area in the vast majority, and can grow. In primary MR, strain is increased even more than normal, still with a larger distribution in the posterior leaflet. With repair, you can decrease strain, and the effect on clinical outcome is really not known at this stage of the game. We're partnering again with the University of Houston to see if we could apply this for MRI, so we could hopefully be able to use that almost clinically in every patient, because you don't want to do obviously transesophageal echocardiography on all these patients. So enough about the pathology and biomechanics of the mitral valve and the question, how do we evaluate malapposition of the valve? Basically, regurgitation, significant regurgitation. It's a guideline. This is our update of a previous 2003 guideline, so 14 years between the two guidelines, and I was honored to be asked to chair it. And in it are some important things for you. If by now you haven't read these guidelines and you're in the field, you'd better catch up. This is about 6 years almost. I mean, time flies. And I'm not volunteering for another guideline. Emphasize identification of the mechanism, an integrative approach. We talk about it, but I hope you will use it. And remember, echocardiography and MRI is no longer the language of an imager. It is the language of anybody involved in this disease. Certainly our surgeons, who know quite a bit about the mitral valve itself. Emphasis and caution, and I'm going to repeat that, on non-holosystolic, basically late mitral regurgitation that happens in mitral valve prolapse, and the important role of cardiac MRI and where we put it. So let's delve into that. And let's see here. Oops. Here we go. Classification-wise, this is a modified Carpentier. Unfortunately, it's a bit difficult. So most of the time in our reporting, you don't see a 3B or 3A, etc. We just describe it, and I think might as well basically describe this. Role of 3D is very important, particularly in transesophageal, and particularly in the difficult situations where you can have prolapse of flail of basically the commissural areas that are difficult to see on a transthoracic examination. Otherwise, a transthoracic or even a 2D transesophageal can really give you what you need. Newer techniques for those of you who are not aware of them, they're really beautiful. It's amazing here that you could see the valve is almost like in your hands, looking at its structure, its abnormalities. Now, for every one of you, including our surgeons, you have to have a methodical approach to evaluate these lesions. And the methodical approach has to be anatomy, color flow, which is your first screener, pulse Doppler and CW. Not ask our surgeons to look at pulse Doppler and CW as much, but beware of color Doppler, which can be misleading, very helpful, but misleading. And if you want to remember one thing, for color Doppler, it is not a volumetric approach, it's a velocity approach. So it's great as telling us where is the jet going, but for evaluation of severity, you have to take a look at the three components of the jet, which is convergence of flow into the atrium, towards the atrium, the vena contracta, which is the smallest area, and the regurgitant area, which can be influenced by direction, by other things. So it is not a volume. So, and that's why we have to take a look at these three components, because it can be misleading. The middle and the right panel are the same severity. To the eye, they look so different. One is very eccentric jet, can be very misleading from a severity point of view. So my advice is kind of ignore, after you see it, ignore what's going on in the atrium. Make sure that you don't forget of what does the flow convergence of the vena contracta look like, because some of these jets are very eccentric and you may not see them in the atrium well unless somebody takes time to do that. An example for you, somebody coming in with significant dyspnea after MI, color Doppler to the uninitiated, doesn't look that impressive, but the vena contracta is quite impressive, very eccentric jet. And this is somebody who is really not doing well. This is rupture of the papillary muscle, severe mitral regurgitation. And you could see how eccentric the jet is. Whenever you see eccentricity of a jet, there is malapposition of these leaflets one way or another. So you always look for abnormality of structure, prolapse, flail, other things that I think you need to take a look at. You hear about PISA and flow conversions. It is an important parameter, but not without its issues. So we keep that in mind because it tells us the more you see of this flow conversions in the ventricle going into the atrium, the more severe the regurgitation is. And most of you know that above 0.4 centimeters squared, if you see this number, usually it's severe. You start some significance above 0.3 centimeters squared. And the same cutoffs are for both primary and secondary mitral regurgitation, regurgitant volume greater than 60 ml. Significant prognostic implications for effective regurgitant orifice area and regurgitant volume. But these are my summary slide for effective regurgitant orifice area and PISA. Always use it semi-quantitatively because it helps you. It has issues, there's no question about it. So you may not be able to measure the numbers through it in, at times, very eccentric jets, or if you have multiple of them, but keep that in mind. The effective regurgitant orifice area may be underestimated in secondary mitral regurgitation, and that's why if you look at the COAP trial, greater than 0.3 centimeters squared is usually used as significance because that can happen. It is certainly less accurate in eccentric jets. It doesn't take away that if you have a lot of flow conversions, it is probably significant. It's moderate and above, and the question is how bad is it? And caution in non-holosystolic mitral regurgitation. Well, interestingly enough, if you stop and think, non-holosystolic mitral regurgitation, there's nothing else in the heart that would split a certain phase of the cardiac cycle for either regurgitation or stenosis. It's only for mitral valve prolapse. Only for mitral valve prolapse. Now in secondary MR you may have a little more early on, a little later on, but mitral valve prolapse, you start with nothing, and later on, and usually it's almost mid-cycle, you start having regurgitation. And why is that important? You could see that on the continuous wave Doppler, that it starts later. So that's helpful if your eye is not calibrated to be able to see that this regurgitation is starting late. This is from the guidelines. Early systole, there's no mitral regurgitation. Mid-systole and later, you see the regurgitation, and it's happening very late. This box is very important for people who are involved in this phase. You cannot use colored Doppler measures of severity. Neither the area, nor vena contracta, nor flow conversions, no effective regurgitant orifice area. Because in your mind, if you have non-holosystolic mitral regurgitation, it's almost half of what you think. Almost half of what you think. The only thing that you could do is measure regurgitant volume where you use this tiny portion of the regurgitation, and then regurgitant volume is almost adjusted by half. Data already showing, quite early, and this is from Mayo Clinic, that if you have non-holosystolic mitral regurgitation, your regurgitant volume is less compared to regular holosystolic regurg. LA volume is less, PA systolic pressure is less, LV volume is less, and your prognosis is better. So where we see major issues is referral for an intervention. Mitral valve repair, usually, in non-holosystolic, where you have the ventricle that has not even remodeled, where the atrium is almost normal or mildly enlarged. You have to be very careful because it is unique for mitral valve disease. You rarely see it in tricuspid valve disease, although tricuspid, prolapse can exist, but you don't see it as much and probably not as significant. What do you do in these situations, or any situation? You could use a volumetric approach, take a look at how much goes into the ventricle through the mitral valve, or measure the total stroke volume from the ventricle compared to what goes out into systemic circulation. And for our fellows, I was a young man then, Dr. Roki, and this is actually the original publication in JACC, looking at regurgitant volume and regurgitant fraction. Dr. Roki has retired. Dr. Liemacher has retired. And Dr. Quinones is still going strong. Advantages of this volumetric is obviously it's quantitative. Doesn't matter whether the jet is eccentric, yes or no. If you have multiple jets, you need training. Yes, it has more variability than others, but I think, you could bracket it. And if you have regurgitant volume of 80, no matter how much error you have significant regurgitation. So keep those in mind, and our fellows always are trained in those, quantitative technologies. So this is from the guideline, an algorithm to help individuals navigate this severity of regurgitation. On the left in green are specific signs for mild, and on the right, specific signs for severe regurgitation. And whenever you have some discrepancies, we ask individuals to do some quantitation. And these are the signs of severe MR. Flail leaflet, or at least moderate to severe, right? Enlarged vena contracta, flow conversions, pulmonary vein systolic reversal, quite specific, and enlarged LV with normal function in somebody with significant mitral regurgitation, telling you that there is a volume overload. In blue are the cautions and next steps. And the cautions are, if you have non-holosystolic mitral regurg, you're going to have to take some of these criteria out and use either a transesophageal echocardiogram or MRI. We suggest an integrative approach, and why? Because it is advantageous. You're taking a look not only of volumes and quantitation, but also, which is unique for Doppler echocardiography, is the hemodynamics, which are very important in mitral valve disease. And in addition, you could take a look at remodeling. Now, MRI is very strong in this situation. And it is beautiful because it tells you in 3D, in a way, what the remodeling of the atrium and ventricle, take a look at the mitral valve pathology, and it is very quantitative. And the quantitation is an indirect approach, meaning you take a look at the total ventricle, and you see what is the systemic output to the circulation, either with aortic or pulmonic flow. And basically, this is how you do your assessment of regurgitation comparison. And the question nowadays is, you're getting a lot of patients with echocardiography, and you may get a report and say, cannot quantitate, and if you're interested in quantitation, do an MRI. And the question is, how do these compare, and what do you expect in those situations? So at least you know what the expectations are. I won't talk about it if the correlation was 1-to-1. So there are issues with either methodologies, but number one is that the variability in MRI of calculating stroke volume and regurgitant fraction is much less than that with echocardiography. So in general, if everything is aligned, the variability is less with MRI. But usually MRI is not your first, your first line of evaluation of such patients. It's usually after there are some questions with the transthoracic examination. It is less, but it is not nil. And in a normal individual, you can get a regurgitant fraction 10 to 15, and we've done that in this laboratory. For echocardiography is more, is probably 15 to 20% variability of mitral regurgitation, where you don't have any MR, you're just comparing flows. Also be careful in atrial fibrillation. So if you have somebody in atrial fibrillation, you have a lot of variability, and particularly if the rate is variable. There are susceptibility artifacts, particularly in ICD. So keep those in mind as to what could be the issues. I'll share with you two things. One, this is an early presentation manuscript by Dr. Uretsky and others. So it's about 8 years old. And we were surprised, the echo community was very surprised that there was significant overestimation of severity of regurgitation by color Doppler. The vast majority of the emphasis was, from a quantitation point of view, was on color Doppler. Yes, using an integrative approach, but no volumetric approach. And the discordance was 62%. And this is nothing that we've seen here. And afterwards, we published on such, and the discordance, the significant discordance where you have more than 2 grades was about 10, 15% or so. And obviously, if you have discordance, the relations are not the greatest, and you can apply, regression after operation of the ventricular volumes. Obviously, it's not going to apply. But there are issues. Use of PISA alone, 47%, almost 50% had degenerative MR, probably some of them with late systolic MR, and using PISA is a problem. Time between the studies was about 15 days. A more recent one last year, looking at the algorithm that I showed you, also with concerns. Now, interestingly enough, I was asked to write an editorial regarding this publication. And the editorial was, besides challenges and opportunities, details matter. And indeed, in this field, details matter. This is more for the echocardiographer. There are many things in the echo evaluation that just did not make sense. 20% of flail had mild mitral regurgitation. 24% with a large flow conversions had mild MR. Vena contracta, which is rather large, 0.7, 25% had mild MR. 20% pulmonary vein reversal had mild MR. Normal LV and LA size in 20% of severe MR. Color Doppler more accurate in eccentric jets, which is pretty much refuted by everybody known to man. So there are issues with this. And, in the background, this is the concern here, is we don't see this clinically. We don't see this clinically, and the question is why? Now, besides the criticism I had, is I wanted to make sure that we send an educational message for people who are doing this. Now, yes, you can have overestimation by color if you're not cautious. Number one, we talked about non-holosystolic MR. 2 is, where do you measure this diameter for PISA? And 3 is, you cannot use PISA when the PISA is very close to the wall of the ventricle, deforming this hemispheric, calculation. Now, in the background, we've been doing for the past 6 years or so a prospective registry of near simultaneous cardiac MR and echocardiography. And I want to thank Clara Angulo, our advanced sonographer, for doing this. She's been shepherding this throughout. 177 patients done near simultaneously, meaning the patient has their MRI study and echo is done usually immediately after or just before. And this is the population: 42% mitral valve prolapse, 25% flail, 20% secondary MR, and quantitating both and doing the evaluation. And Dr. El Talawi has been spearheading this, in addition to Dr. Shamsi Pasha from the cardiac MRI, obviously with Dr. Shah, Deepan Shah, and ourselves, etc. I'll show you a snippet of it because this is not published data, and I actually submitted data. Correlations about 0.7. No systematic over or underestimation, but the exact concordance for a 4 grade is 53%. That's for the total population. You would allow clinically for a 2 grade discordance, meaning if I say it's mild, then mild to moderate or just 2 grade difference is about 86%. So in about 10 to 15%, just like we had before, you will have significant discordance, and then the clinician has to go back and see why and which one had issues. Was it physiologically different? Is this secondary MR? In secondary MR, it is more problematic because it's very dependent on blood pressure and many other things. So keep those in mind as you go. And this is my conclusion slide regarding MR and echo. They are complementary. Variability in MR, we know it is less. Clinically significant discordance between of them is infrequent, 10 to 50%, but not negligible either. Knowledge of these modalities is important, and if you have a discrepancy, you really need to go back. From my recommendations to you, and this is not in the guidelines. If you are doing a transthoracic examination and you need more information, what would tilt you to transesophageal echocardiography is knowing the mechanism, concomitant atrial fibrillation, if I have a susceptibility artifact, if I have prosthetic valves are needed at the bedside. What favors MRI is quantitation. Certainly in secondary MR, if I'm looking for viability and scarring, I think that's going to be important. But the big issue is quantitation with cardiac MRI. Newer observations. Barlow disease is an interesting disease because you could see the prolapse of both leaflets, and there is a little exaggerated motion of the mitral valve. And we know clinically that there is a cardiomyopathy related to this disease in a way. The ventricle is bigger than usual or depressed. And I think Dr. Al-Talawi and Dr. Shah have been instrumental in looking at this mechanism and trying to understand it. And part of the understanding is you cannot ignore the prolapse volume that is occurring in addition to the mitral regurgitation. So the LV diastolic volume overload, by hypothesis, should encompass both the prolapse volume and the regurgitant volume that you see, that you could see by echocardiography or by jet, etc. And this is what they did. Actually, this was published about almost 2 years ago now. And it's interesting that this prolapse volume can be quite large. It can be about 30 ml, can be 40 ml at times, which is a significant volume. And it is additive to the regurgitant volume. So you cannot completely ignore it. And the data actually shows that the remodeling of the ventricle, if you incorporate the prolapse volume in the lower panel, left lower panel, then features the remodeling that you see with single leaflet prolapse and the volume. So you cannot ignore it. And how do you do it nowadays? I know in our laboratory we incorporate it, so it is written as prolapse volume, regurgitant volume in addition. In echocardiography, we're still wondering, and I think no pressure, Dr. Al-Talawi, but we need to come up with some guides for us, but we cannot ignore it. So if you see somebody with bileaflet prolapse Barlow disease, the ventricle is quite big, the left atrium is quite big, the regurgitation is not as impressive, think about that mechanism, because I've seen some patients with that, and it will change the reclassification significantly. Significantly. You know, take a look at it. From mild to moderate to severe is 21. 21 cases in this. So you cannot ignore it, and I think this is a new concept, rather new, within the past 2 years, really, of how do you evaluate severity of disease in degenerative mitral regurgitation. What do we do with patients like this? So let's talk about management, and this is, you know, the latest focused update from the ACC with Pat O'Gara and Bob Bono. So we talked about pathophysiology, assessment of severity, et cetera, but I think in this disease we have to think about risk. This disease is very different than many of the other diseases that we have in valvular heart disease. And why? First is, what is the risk? What are we trying to avoid if we want to tackle this individual? We want to avoid excessive cardiac remodeling because it becomes irreversible, LV failure, myocardial fibrosis, and there is a substrate of such individuals who have significant ventricular arrhythmia and sudden death, pulmonary hypertension, RV failure, atrial fibrillation that we usually don't think about it immediately for mitral valve disease, but because of its embolic risk, and anticoagulation risk, I think it's part of it, and sudden cardiac death. And the interesting thing about degenerative MR is it is amenable, as opposed to many of other diseases, to surgical repair. And in the right patient, you can get 95 or more % success with little MR and with good longevity. And the question is, how do you identify such patients? And that's why we don't see as much. We don't see as much the very advanced disease unless they're not having care anywhere. So this is the ACC guidelines in 2020. The interesting thing enough to me, and I talked to Nishimura and Dr. Otto, it is so simplified, and the question is, are we missing something? And the simplification is, if I have somebody who's severe MR and asymptomatic, the only two criteria that I'm looking for is an EF, less than 60%, and LV size and systole dimension of 4 centimeter. Progression, everything else in between, fine. And I look at the success of repair. Is this enough? With everything that we know, it may be enough, but I'm not sure. I'm really not sure. In the guidelines, European guidelines, there is atrial fibrillation, pulmonary hypertension, which we used to have, no longer have here. And the question is, what else do we know about this disease? We know left atrial size is important. Now, is it important by itself? Not sure. But in analysis, you could see that above 60 ml, higher risk for both patients in normal sinus rhythm or atrial fibrillation. We know that regional fibrosis is important. Now, it could be with Barlow disease more often than others, but I think we have a technique nowadays, MRI, that can look at regional replacement fibrosis and quantitate it. And actually data from here, Danai and Dr. Shah and many other investigators have shown that in primary MR, in mitral valve prolapse, as severity increases of the regurgitation, also the amount of replacement fibrosis increases significantly. And these are the individuals who have much more significant arrhythmias. With MRI, we could quantitate interstitial fibrosis. So it is the diffuse replacement, not replacement, but diffuse increase in ECV. And it has significance also. And the question, how do we put this all together? 3 days ago, just 3 days ago, 2 articles came in JACC Imaging using machine learning, which is something new to mitral regurgitation, not to other diseases of valvular heart disease, but new to mitral regurgitation. What are we going to gain from machine learning or AI in this situation? Well, this is one. And this one, they look at clusters. And in a large population of mitral valve prolapse, more than 400, without boring you with all the details, the determinants of clusters, the worse the cluster, and they had MRI also, the worse the cluster, the worse the prognosis. And in it, there were 3: severity of regurgitation, LA volume index, and LV contractility using global longitudinal strain, and the cutoff was 21%. For those of you who know what global longitudinal strain is and what normal is, usually it's about 18, lower limit of normal is 17. So you would require a GLS that is almost hyper, contractile hyperdeformant, just like we require a 60% cutoff of regurgitation, and at times maybe 60%, maybe a little too late in some of these individuals. Another paper from Dr. Sengupta, again 3 days ago, using AI with echocardiographic criteria. On the left is 24 echo criteria to try to differentiate individuals with a low severity versus high severity, and the outcome here is success at surgery and outcomes at surgery. And what they looked at basically is, I'll give you the summary of here, is that the determinants of who will do well is end diastolic volume, not a linear measurement, EA prime ratio, basically filling dynamics, regurgitant volume by PISA, and thickness, basically LV mass or something like this. Basically, there are other parameters that may be important in this. So I was asked, sorry, Dr. Chandra, but I was asked on my vacation to write an editorial with him regarding what are some of the unanswered questions in primary mitral regurgitation. And these are our thoughts. One is, since I mentioned to you already that the population that we're seeing now is different than the population we saw 15, 20 years ago. These are not the advanced ones. We're tweaking as to, because we have good surgical techniques in the vast majority of patients, in these patients, is to identify those who may not do well. So your sensitivity has to be high, hopefully in a good surgical center. And the question is, where do these fit? LV volume versus linear dimension, LV strain, LA volume, prolapse volume, a new criterion, if you will, to look at severity. MRI, what do we do with MRI? All these data that we have. Yes, it may not be applicable to all the patients. And risk stratification, I think this is a problem. The last one is a difficult thing. It's much more in the EP realm, if you will, but it can be devastating in the young individual with mitral valve prolapse with sudden death. And I'm seeing few of these patients who are lucky enough to still be alive. So these are to me the unanswered questions. And for us to answer these, you're not going to be able to answer them in a single center. You have to have very large numbers using all the techniques that we have, hopefully to come up with criteria and test them. You're not going to have randomized trials in these situations. But at least some of these registries would be important. Last few things about management. One is for degenerative MR, repair techniques are certainly the ones. And Dr. Lowry, actually one of his series is right here, certainly has been our pioneer in mitral valve repair. And you could see, if it is repairable, I don't know, Dr. Lowry aims for 100%, but in degenerative MR, you could do it close to 100% of the time in a great center with preservation techniques as opposed to a Carpentier technique. Some people still use it, but irrespective, hopefully we aim to eliminate mitral regurgitation. You're not going to eliminate the disease because chordal rupture can occur later. The disease is still there, but I think the outcomes overall are good. Patients at times, they could be high risk in this situation, and obviously transcatheter approaches have evolved so much. The role of the imager in addition to the interventionalist is crucial in the cath lab to be able to do that, and we're not going to go through criteria, et cetera. But it can be a challenge for the echocardiographer and the interventionalist looking at what is residual after you do an intervention. I was asked to chair a new guideline now 4 years ago, time is flying, as to how do you evaluate such patients after an intervention. A picture from it, I think a great marker of success is that if the hemodynamics get much better. Take a look on the right side. Here you have reversal in the pulmonary veins, systolic reversal. Here you have resurrection of the systolic wave, in addition, obviously, to lesser vena contracta and color Doppler, etc. I will highlight one of the studies that in our lab, Dr. Sachin Goel and many of his postdocs are really working on a very large series here, looking at various ways of trying to predict outcome and see feasibility, and if it's not feasible, what it is. But I like this study very much, which is submitted and I think presented in an oral form at the national meeting, is that you could take a look at pulmonary veins right here, just like I showed you. But also you can take a look at hemodynamics. What are you left with in the left atrium? If the left atrial pressure is greater than 15, you may still be in trouble from a prognosis point of view, and obviously MR reduction. So MR reduction, pulmonary veins improvement, in addition to a left atrial pressure that you're left with. And this is in the catheterization laboratory while the interventionalists and the imagers are doing such. TMVR is an evolving field, and a lot of investment in this area. Hopefully it will pan out in something good that we could apply in a large number of patients, and we cannot apply them in a large number of patients. Part of the issue is changing the LV outflow tract and causing obstruction. So this neo-LVOT is a problem because of the bulkiness, if you will, of these And there are many innovations to try to do that, so obviously the field is changing. What is the role of the imager? Is to try to understand if you put a valve, what happens to the neo-LV outflow tract, and you could see it very narrow here. And I'll share with you that we were wondering at some point in time, when does digital modeling occur? And I think it's really beautiful to understand how calcium will deform as opposed to not, because many of these mitral annuli could be very calcified. So it is an evolving field. So we don't have to, down the line, do any 3D printing or to try to understand what the situation is. And I think this is really an evolution of the field. So what I try to share with you today is mitral valve disease, not only from a clinical point of view, biomechanical point of view and mechanism, but also some of the newer concepts of how to assess severity, if you will, and the questions and the many questions we have regarding risk assessment. And the risk assessment is pretty much in the asymptomatic patient, where you could do an intervention early enough to change the course of the disease for the better in these individuals. And I think we have a lot of work to do. And the management of transcatheter techniques nowadays is really amazing for us as to discoveries of newer ways to tackle this disease. So thank you very much for the opportunity, and it's great to be with you this morning.
Thank you. Before I get there, Gerald, just let me say, I can't think of many institutions that have contributed more to the understanding of the mitral valve, from your leadership, Dr. Quignoni's leadership, Dr. Lowry's leadership, and we'll ask him to comment in a moment. But I think what you also showed is this transition. Dr. El-Talawi's, what he's been contributing to this, the DPANS group. I think it's tremendous, and I really want to thank you all for your contribution to that. So, Dr. Lowry, I would like to invite you to comment.
Thank you very much. Excellent talk, Bill. I think you've highlighted some extremely important and unresolved areas. The timing of surgery still is really a difficult issue. At one extreme, we get these people that have completely normal ventricles, no sign of any hemodynamic compromise, who are totally asymptomatic, and I think we all are in agreement that these people can be safely followed carefully, sometimes for quite surprisingly long periods of time. At the other extreme, we have people who are referred in congestive heart failure because they've gone off the deep end. And I think we can say, based on from the wealth of data you presented, that when it really comes down to it, whatever measurement you want to use, these are the people that could end up in serious trouble much sooner than you might expect, and they do require vigilant follow-up. You're going to follow them, be very, very careful about how you do that. And I think the guidelines still indicate that medical therapy really has very little role in the management of primary mitral regurgitation.
Gerald, number one, obviously I fully agree with what you mentioned. Number two, I want to thank you, since you're here in the audience, for the collaboration over the years, and it has been many, many years, on trying to understand more the mitral valve and its approaches and how we do things. In follow-up to your comments, I have two comments. One is, when you mentioned normal LV function size, almost normal left atrium, although left atrium is very sensitive to many things. If you have an asymptomatic individual with normal LV function and normal LV size, asymptomatic, normal LV function, normal LV size, this patient cannot have severe mitral regurgitation. So you have to look at how did you assess the severity of regurgitation, and most often it is usually mitral valve prolapse with an overestimation. I'll tell you, I've traveled the world, and I know quite a few interpreters rely so much on colored Doppler jet area that can be misleading. So unless you have an integrative approach similar to what I shared with you today, you're going to be in error. Two is, if you ask me, what is the highest variability in assessment of valvular disease? I will tell you it is mitral regurgitation. Variability. We see all over the place. And I think the more we talk about it, the more hopefully we address some of these issues, the more hopefully people in the field will quantitate and know how to take the time, because these are major decisions on patients. And I cannot thank you enough, Dr. Lowry and many of our surgeons who come in and said, can you review the study? Because either it doesn't make sense, and I know you guys order also MRI, which is fine. I have no issues actually with that. That's probably the best way to decide whether there is an issue, yes or no, and resolve it. But I think it's very important because this is an intervention, irrespective of what intervention it is. So we want to make sure, and we don't want to see the extreme either, a depressed function, et cetera, et cetera. So we want the threshold to be low for an intervention, but we want it to be appropriate at the same time. And that's why, we talked about where is the risk nowadays.
Dr. Quinones.
Beautiful talk. Bill, just a great, fantastic assessment. But I have a brief comment and a question. So the comment is, when we look at this prolapse virus patient with the regurgitant volume, not the volume, the product volume, it reminds me a lot about apical aneurysm. Like you have this beautiful base and even some middle segments contracting great, and then you have that bulging in the apex. And you have blood that is being wasted at the apex. And I think that the prolapse volume, in a way, is an analogy to the same situation that we have with aneurysms. I'm wondering, I don't know, if there's a way that we could do a comparison of the two in terms of volumes and whatnot. Because I think the mechanics are kind of similar. You have this amount of blood being wasted there, but at the end of the day, it contributes to the enlargement of the LV and everything else. That's just a comment. Now, the question is this. This is what really been bothering me now for a while, is that when you put together evaluation of the MR with all the beautiful points that you brought in, and then decision-making for when to do something, and then the actual treatment, whether it is repair, whether it's a clip, etc., we are talking of a significant level of complexity. And mitral regurg patients are all over the country. The majority probably going to community hospitals, not to big medical centers. So I'm concerned from a national point of view, how do we do this? How do we export all of this to the community hospitals? Are we going to be requesting they all send their patients to big-time medical centers? So to me, that is an area of concern, because the average cardiologist in a small town may be doing one of two things. Maybe sitting on that patient too long because he doesn't know where to send it. He's concerned about their local doctors not being good enough. Or the other extreme, using people that don't have all the expertise. So to me, from a national health situation with mitral regurg, I have a concern about that. I'm just curious about your thoughts. I'm sure you have thought about this too. And I'm wondering whether a group of experts may be thinking of getting together and maybe putting some guidelines about that. Because the guidelines always say, mitral repair in a center with good result. But I mean, it's nice to say that. But to put it into practice is a whole different ballgame. So I just wanted to hear your thoughts on that.
That's a difficult issue. Many of these guidelines of how do you assess severity of regurgitation have been there for some time. And in truth, for color Doppler and volumetric, these have not changed since 2003. 2003 was the new emphasis of mitral valve prolapse. And yet, we have so much variability out there. So this is why I wrestle with, is how do you motivate individuals to practice and educate themselves, who are not in big medical center. All of you are here to try to listen to something new. And the question is, how do you motivate people in the community who are doing such and who are doing echocardiograms and maybe not sitting down and as much, because it takes time. And fortunately or unfortunately, whichever way you look at it, reimbursement is the same. So it is a question. So this is even from a diagnosis point of view. From a referral point of view, I do hope that people are aiming for the best of their patients. And if after a while, their referral to their own surgeon is ending up with predominantly mitral valve replacement, I hope there's some conscience somewhere to say, although I love you as my surgeon, et cetera, but when it comes to mitral valve as opposed to the other valves, this is where you can make an impact. Because the other valves are not as repairable as this one. So education is big. Reach, how do you get there? Let me tell you, the reach nowadays with digital, everything is digital, ACC things are sent out to all their members. I mean, you got 30,000 members, right? What do you do about it?
Okay, so it's after 9 o'clock. Let's have 2 more questions. Mike?
Real quick, great talk, number one. Number two, I want to echo what you said about Gerald. Gerald has been a global leader in mitral valve repair. You talk about being able to send somebody someplace where you know it'll be repaired. We're fortunate to have that. So cardiac surgeons are becoming more like interventional cardiologists. Interventional cardiologists are becoming more like cardiac surgeons. And now we're adding a third group, and that's the interventional imager. We can't really do tier transcatheter mitral transcatheter tricuspid without an expert imager. The success of our procedure is heavily dependent on the imager, but they don't get paid. How are we going to make sure our imagers are properly compensated for the time they spend doing a long procedure as opposed to reading 20 echoes?
So before you answer that, let me piggyback on a question that's relevant to what Dr. Q asked and what Mike's asking. If we needed you to remote in to the operating room to look at a TEE in this institution today, can you do this from the reading room? So I guess that's...
It's very interesting. No, it's very interesting because there's an evolution to this. In the early days where the team was doing intra-op imaging, etc., we had a physical connection to the operating room, to each one of our operating rooms.
Yep.
And we had a TV, remember those? Not flat, a TV that somebody said, room 3, so you push room 3 and you could see it.
Yep.
Now, actually, since we trained quite a few of our anesthesiologists, they're doing it in there. So we have less of that urgency, but at times we're called in.
Right.
And you go.
Well, but it also partly addresses the question, because I know Steve's itching to say something about interventional echo.
Let me answer the Mike's question.
Yeah. All right, so obviously I hit a hot button. Gerald, and then Deepan, and then we're done.
Just a quick further to Dr. Quinones' comment. We've just had the 2023 Society of Thoracic Surgery database of the state of mitral valve repair in the United States as of 2023. Overall, 80% repair rate of primary MO. We've been running 100% for 20 years. We have new techniques that evolved, Zoghbi and improved. Cutoff seems to be to get any level of confidence whatsoever at someone. The average surgeon in the United States doing between 5 and 10 mitral valve repairs a year. All the major centers are going to be doing 100 to 150 a year to be confident. My big concern, frankly, is I don't think we're going to be able to change much without more education, which is going to be the key. My big concern is that in the community hospital now we've got this new generation of clip with about a 98% procedural success. The cardiologist is going to look at his surgeon who's doing very poor mitral valve repair. He's going to look at a young patient with a nice big permanent valve and decide to just clip it. And I think that's going to be a big education because that will happen. That's not yet improved for the long haul, and it's going to be a people to be a
Thanks, Gerald. Bipan, I do believe he said he doesn't mind if we order MRI. I knew you'd have to rise to that bait. Go ahead.
I think, it's coming through.
Yeah, it's coming.
Okay. So, Bill, I think one is a very nice, balanced talk, and I think you really touched on some of the key concepts. The question I have for you, because I think right now, one of the things we touched on was the fact that patients with severe MR, if they're symptomatic, obviously you operate, and if they're asymptomatic, we look at certain remodeling criteria and things like that. I think another challenge that comes up is these patients that have moderate MR, but they're symptomatic, right? And I think especially now with all these other comorbidities, hypertension, LVH, you see this a lot in older women. Maybe share with us how you approach these patients.
Whenever you hear moderate MR, meaning it's not mild. And you may want to take a look as to what's going on in this ventricle. How much remodeling there is in the ventricle. How solid is this moderate mitral regurgitation? What does the quantitation tell me? And remember that the quantitation has a certain delta to it. So you want to see whether the symptoms are related to the disease itself or to something else, because the symptoms are dyspnea. So it becomes a little issue. Yes, you could do some BNP, etc., to try to understand from a physiology point of view, is there something else? But I would take a look at it and see if actually the ventricle is on the larger side without any other reason for it to be large. And the atrium is quite remodeled, and the MR could be moderate to severe, and a ventricle that may be less compliant than others, you may have symptoms from there. And you want to know whether the symptoms are related. So these are at times individuals that either you stress or you take to the cath lab to find out what the filling pressures are. So you use, these are challenges, and for each one may have a little different answer.
All right, 9:10.
9:10.
Yeah, we did well. Thank you very much indeed, Bill. It was fantastic.
Thank you.
But just before everybody leaves, let me introduce the people who you can contact for DeBakey Education. Chris, put your hand up. Chris Ibarra, Stuart Core, and Tyree are the three people. As I say, use the system or lose it. Thank you very much. That was awesome. Good job.
Hey, man.
You want anyone else to photo this? Yeah.